Hi, this is Dr. Vallesh. Welcome to Pharmacology Simplified. In this video, I am going to speak about special properties of beta blockers. This topic is important for your theory exam, Viva, and for your entrance tests. Now, there are four special properties of beta blockers: cardioselectivity, lipid-insolubility, membrane stabilizing activity, and intrinsic sympathomimetic activity. These are the properties which differentiate different beta blockers. These properties provide special pharmacokinetic and pharmacodynamic advantages to the beta blockers in question. Out of these four, cardioselectivity is an important topic by itself. I have covered that in more detail in a separate video. The link for that video is available in the description to this video. Okay, so let us start. Cardioselectivity, in other words, means the beta blocker is blocking only those beta adrenergic receptors that are located in the heart. In the heart, there is only beta 1 type of adrenergic receptors. So cardioselectivity, in other words, means beta 1 selective blockade. Okay, this has certain advantages and certain disadvantages. Advantages can be summarized as A, B, C, D, E. A is for asthma. Since these drugs do not block beta 2 receptors located in the respiratory tract, they do not produce bronchoconstriction. So these drugs are safer in asthmatic patients and patients who are having COPD. That is for A. B, blood lipid profile. These drugs do not produce that much deleterious effect on blood lipid profile, because the effect on blood lipid profile by adrenaline or by beta blocker is through beta 3 receptors. Adipocytes located on adipocytes beta 3 receptors leading to lipolysis. This is blocked, leading to a deleterious effect on blood lipid profile. Now, since beta 1 receptor specific blockade does not lead to all these effects, cardioselective beta blockers do not have or have less deleterious effect or less harmful effect on blood lipid profile. So B for blood lipid profile. C is for cold hands and feet and less chances of precipitating Raynaud's phenomenon. Now, how this is seen in non-specific beta blockers? Beta 2 receptors are located on the blood vessels. Beta 2 receptors activation leads to vasodilatation. If you use non-specific beta blockers, beta 2 receptors are blocked. So when adrenaline is released, it does not have beta 2 receptors to sit upon. It will sit and activate on alpha 1 receptors, leading to vasoconstriction. The vasoconstriction in the periphery, in the hands and feet, leads to cold hands and cold feet, and it will worsen. The patient is already having Raynaud's syndrome. It is going to worsen that. But if you use cardioselective beta blockers or beta 1 selective blockers, they do not block the beta 2 receptors located on the blood vessels. And as a result, this is safer in patients who are prone to develop Raynaud's syndrome. So C for cold hands and feet. D is for diabetes. Non-selective beta blockers often interfere with carbohydrate metabolism. The cardioselective beta blockers, on the other hand, they have action only on beta 1 receptors. They do not have action on beta 2 receptors and other receptors. As a result, they are safer in patients who are having diabetes. E is for exercise capacity. The beta 2 receptors, which are located on the blood vessels, which are supplying to the skeletal muscles, if non-specific beta blockers are used, these beta 2 receptors located on the blood vessels supplying to the skeletal muscles undergo vasoconstriction. This leads to decreased blood supply to the skeletal muscles. This will impair the exercise capacity. This is seen when we are using non-selective beta blockers. But if we are using cardioselective or beta 1 selective beta blockers, this effect is not seen. The beta 2 receptors, which are located on the blood vessels which supply to the skeletal muscles, are unaffected by cardioselective beta blockers, and hence these cardioselective beta blockers are less liable to impair exercise capacity. So these are the advantages seen with cardioselective beta blockers. What are the disadvantages? There are two disadvantages, both start with T. First one is tremor. Okay, these the cardioselective beta blockers block only beta 1 receptors. The tremor, suppression of tremor due to beta blockers, is because of their inhibitory action on beta 2 receptors, which are located in the skeletal muscles. Adrenaline activates beta 2 receptors on the skeletal muscles, leading to increased potassium uptake and tremors. This is not blocked by cardioselective beta blockers, because this is a beta 2 mediated effect. Okay, the second disadvantage is another T, that is tachycardia. The body has developed certain mechanisms to warn the person if there is hypoglycemia. Between hypoglycemia and hyperglycemia is always more dangerous. So the body has developed certain mechanism to warn the body if there is hypoglycemia. One of the warning mechanisms is tachycardia. That tachycardia is mediated by beta 1 receptors. If you are using cardioselective beta blockers, this tachycardia in response to hypoglycemia is blocked. This is not a desirable outcome because we want the person to know whenever there is hypoglycemia. So this tachycardia in response to hypoglycemia is blocked, and this is a disadvantage. These are the advantages: A, B, C, D, E. A for asthma, B for blood lipid profile, less harmful alteration, C for cold hand and feet, Raynaud's syndrome, D for diabetes, D for excess capacity. Whereas disadvantages are two: one is tremor, essential tremor, second one is tachycardia. Which are all the beta blockers which have this cardioselective property? There is a beautiful mnemonic for this, you might be already knowing this. New beta blockers acting exclusively at the myocardium. So N for nebivolol. Nebivolol is the most cardioselective beta blocker. This is frequently asked in your entrance exams. Okay, two B's are there. First B is betaxolol, second one is bisoprolol. Both of these are cardioselective beta blockers. A for atenolol. This is one of the more popular beta blockers that is being used. E for esmolol. This is the ultra short acting beta blocker. It is ultra short acting because it is metabolized by esterases that are circulating in the blood. This is another frequently asked question in your entrance exams. Another A, acylbutylol, M, metoprolol, and C, celiprolol. These are the cardioselective beta blockers. Moving on, the second special property that is seen with beta blockers is lipid insolubility. This provides pharmacokinetic advantage to some beta blockers. So, if a beta blocker is lipid insoluble, it means that this drug cannot cross the membranes, various membranes in the body with that much ease. Remember, for crossing the membranes, the drug has to be lipid soluble. So, if a beta blocker is lipid insoluble, it cannot cross the membranes easily. This will impart certain pharmacokinetic advantages and disadvantages. So, what are all the four major headings under to describe pharmacokinetics? Absorption, distribution, metabolism, and excretion. So, let us examine what are all the implications of lipid insolubility. Absorption: if the drug is lipid insoluble, its oral absorption will be incomplete. Simple, isn't it so? Second one is distribution. If the beta blocker is lipid insoluble, it is not that easily distributed into the CNS, and as a result, the CNS adverse effects, especially sleep disturbances, nightmares, mental depression, is less often seen with these drugs. Distribution. Third one is metabolism. The lipid insoluble beta blockers do not undergo metabolism. To be specific, they do not undergo first pass metabolism. Finally, elimination. These drugs are lipid insoluble, so they do not undergo metabolism, so they depend on the kidney for their excretion. They are excreted unchanged, they do not undergo metabolism, they are excreted unchanged in the urine. So they depend on the kidney for their excretion, and as a result, if you are using these drugs in a patient and the patient develops renal failure, you should stop these drugs. These are all the pharmacokinetic implications of lipid insolubility. As such, the duration of action of lipid insoluble beta blockers is long because they are lipid insoluble, right? They tend to persist in the body for a longer duration of time. On the other hand, if a beta blocker is lipid soluble, it is primarily metabolized in the liver because it is lipid soluble, right? It can easily enter the liver, it can easily cross the membranes, enter the liver and undergo metabolism. On the other hand, they have shorter half-lives. They undergo metabolism quickly, they are excreted in the kidney, they are having shorter half-lives. Okay, so lipid insolubility provides pharmacokinetic advantage and disadvantage to various beta blockers. So, which are all these beta blockers which have lipid insolubility as a property? Again, there is a beautiful mnemonic: not soluble, ABC. N for nadolol. Nadolol is the longest acting beta blocker. This is another point for your entrance exams. S for sotalol. A, there are two A's, atenolol, acylbutylol. There are two B's, betaxolol, bisoprolol, and there is only one C, that is celiprolol. All these are the list of lipid insoluble beta blockers. We have finished cardioselectivity, we have finished lipid insolubility. The third special property is membrane stabilizing property. What is the meaning of this membrane stabilizing property? There are some cells in the body whose cell membranes is not stable. These cells have their cell membranes which are frequently undergoing excitation. Okay. These cells are nerve cells and muscle cells. There are certain beta blockers which stabilize the membranes of nerve cells and muscle cells. In other words, these beta blockers with membrane stabilizing property reduce the excitability of these cells, that is neurons and muscle cells. The excitability of these is decreased because of the membrane stabilizing property. Again, this is pharmacodynamic implication. So what all, there is also a pharmacokinetic implication as well. So what is the outcome of beta blocker having membrane stabilizing property? So these membrane stabilizing property is prominent in two type of tissues. One is nerve, other one is muscle. So in the nerve, if the excitability is reduced, that will lead to local anesthetic action. And in the muscles, especially in the heart muscle, the membrane stabilizing property is claimed to contribute to the antiarrhythmic action. So membrane stabilizing property has these two pharmacodynamic implications. There is also a pharmacokinetic implication. If a beta blocker is membrane stabilizing, it will cause local anesthetic action, and as a result, if you administer this beta blocker through the intraocular route as eye drops, what it will do? It will anesthetize the cornea. Corneal surface becomes anesthetized. Is this desirable or not desirable? Of course, it is not desirable, because you want the cornea to be sensitive. If a foreign body is sitting, you want the person to know about that. If the cornea is anesthetized, it might lead to injury to the cornea. So those drugs, those beta blockers which have membrane stabilizing property should not be given through the intraocular route. Okay. So let us see which are all the drugs, which are all the beta blockers having the membrane stabilizing property. Again, there is a beautiful mnemonic for this: possess membrane stabilizing or local anesthetic property. P for propranolol. Propranolol is having maximum membrane stabilizing property, and this is also the reason why we should not use propranolol as intraocular formulation. M for metoprolol, O for oxprenolol, L for labetalol, A for acebutolol. Again, third time we are saying acebutolol. P for pindolol. So all these are the beta blockers which are having membrane stabilizing property. Moving on, the fourth property is called intrinsic sympathomimetic activity. Now we are dealing with beta blockers. Blockers in the sense they are antagonists. They block the action of the agonist. Which is the agonist for all the beta receptors, and for that matter for all alpha receptors it is adrenaline or noradrenaline. What beta blockers are supposed to do? They are supposed to sit on these receptors and block the action of the intrinsic agonist. These drugs which are having intrinsic sympathomimetic activity are not antagonists, they are partial agonists. What is the meaning of partial agonist? They occupy the receptor and they will mildly stimulate the receptor. In comparison, an agonist will occupy the receptor and fully stimulate, fully activate the receptor. These drugs, what they do? They occupy the receptor, they block the agonist from sitting on the receptor, they themselves sit on the receptor and they will activate it mildly. So the net effect, what is the net effect? Net effect when compared to agonist activation is, the effect is less. Understood? So that is the meaning of intrinsic sympathomimetic activity. They block the action of the agonist, but they themselves activate the receptor in a mild fashion. So they cause partial activation of the receptor, and this activation is less than that caused by full agonists. So which are all these drugs, which are all these beta blockers which have intrinsic sympathomimetic activity? Again, there is a mnemonic for this: contain partial agonistic activity. So contain CO, C for celiprolol, O for oxprenolol, P for pindolol and penbutolol. Two A's are there. First one is alprenolol, the second one is acebutolol. So again we are seeing acebutolol under the special properties. So these are the drugs, these are the beta blockers which have intrinsic sympathomimetic activity. Now the exact outcomes of the intrinsic sympathomimetic activity, whether it is beneficial or harmful, it is not exactly known. The advantages and disadvantages are only proposed. It is not exactly known whether it is actually advantageous or disadvantageous. All these are probable advantages, probable disadvantages. So what are the probable advantages? In the heart, one of the adverse effects of beta blockers, whether it is cardioselective or non-cardioselective, is that it will worsen bradycardia. It will block the beta 1 receptors. Beta 1 receptors function is to increase the heart rate, force of contraction. If beta 1 receptors are blocked, it will lead to decrease in heart rate. If the patient is already having bradycardia, that will be worsened. If the patient is already having partial heart block, it will be converted into complete heart block. If the patient comes to you, is having partial heart block, prone to develop bradyarrhythmias, and you are supposed to prescribe a beta blocker to him, you should prefer a beta blocker with intrinsic sympathomimetic activity, because it will occupy the beta 1 receptors and it will mildly stimulate it. It will not completely block the action of adrenaline on beta 1 receptors. It will mildly stimulate the beta 1 receptors. So there is no that much problem of developing bradycardia or that much problem of partial heart block getting converted into complete heart block. This is one real advantage of beta blockers with intrinsic sympathomimetic activity. The second one is something called withdrawal supersensitivity. What will happen is that you prescribe beta blockers for a long duration of time. After a long duration of time, if you stop beta blockers, what will the beta receptors do? They will come back with a vengeance. All this time beta receptors were blocked, they were suppressed. Now you suddenly stop the beta blockers, what will happen? Beta blockers will come up, they will start hyperacting. So this is called as withdrawal supersensitivity. This problem is less seen with a beta blocker which is having intrinsic sympathomimetic activity. Why? Because these drugs are not completely blocking the beta receptors, they are mildly stimulating it. And as a result, when you stop the drug, the withdrawal supersensitivity, the development of withdrawal supersensitivity, the chance of that is less. So this is a second advantage. The third advantage, which is not actually proven, is that there is less chance of deleterious outcome of blood lipid profile. This is the third advantage. There are certain disadvantages as well. These are partial agonists, right? So beta 2 receptors are not completely blocked. There is mild stimulation of beta 2 receptors. So beta 2 receptor activation will lead to dilatation. So migraine prophylaxis, the rationale of using beta receptors in migraine prophylaxis is that they will produce vasoconstriction in the cerebral vessels. So if you are using these drugs which are having intrinsic sympathomimetic activity, they will not produce vasoconstriction. On the other hand, they will actually dilate the cerebral vessels. So it is not effective in migraine prophylaxis. They are also not effective in secondary prophylaxis of myocardial infarction. The idea behind using beta blockers for secondary prophylaxis of myocardial infarction is that the beta blockers block the beta receptors in the heart, leading to decreased work, decreased oxygen consumption, decreased oxygen requirement by the heart. But what these drugs do, they will mildly activate the beta 1 receptors. So these drugs are not suitable for secondary prophylaxis of myocardial infarction. Okay. Now let us look at the quick review. We have finished all the 4 special properties. Let us have a quick review. Which is the most cardioselective beta blocker? Answer is nebivolol. Which is the longest acting beta blocker with the longest duration of action? Another N, that is nadolol. The property responsible for duration of action is lipid-insolubility. Which beta blocker has the maximum membrane stabilizing property? The answer is propranolol. Finally, which beta blocker has all 4 special properties, that is cardioselectivity, lipid-insolubility, membrane stabilizing action, and intrinsic sympathomimetic action? The answer is acebutolol. So I hope I have been able to simplify this topic for you. If you have any doubts, please ask that in the comment section. I will address them. Thank you. Namaste. Have a nice day.